I'd like to focus my talk this afternoon on two controversies in the management of acute type A dissection. The first is a brief consideration of what to recommend for octogenarians, and the second part is perhaps a more detailed consideration of the current trend toward extending the classic repair for type A. Now, this 2001 paper from Siena, Italy, generated a lot of discussion. They reported on 24 octogenarians with a hospital mortality of 83%, 100% complication rate, and none of the discharged survivors, which was only 4 patients, was able to function independently. The 6-month survival was 0. So justifiably, on the basis of their experience, the authors recommended a non-operative approach for octogenarians, and that generated a good deal of publications on both sides of the issue. Perhaps a more international perspective can be had from the IRAD database. This is a recent publication with nearly 1,000 acute type A's. But you can see there's only 50 in the 9th decade, between 80 and 90 years old, and only 5 patients in the 90s. This shows the use of surgical management in red versus medical management, and you can see that medical management usage rose with increasing age. But what was surprising to me is that it started to rise in the 60s, and it rose to almost a quarter of patients in the 70s and half of patients in the 80s. And likewise, surgical mortality rose with age, rising from around 20% to around 40% in the 80s. So in this context, I wanted to present our results with 7 years of 101 consecutive type A cases at Westchester Medical Center. And we compared a cohort of 21 octogenarians with mean age 85 and age ranging from 80 to 91 with a cohort of 80 younger patients. The younger patients had more malperfusion, were more likely to get a Bental procedure, and the mortality for the younger group was 9%. I added the shock data here because Westchester is a level 1 trauma center. We receive patients by stat flight helicopter from a 100-mile radius. And early on, we adopted the University of Pennsylvania protocol where these patients are admitted directly to the operating room. So a number of patients are admitted in shock, some with full CPR, and we have a strict definition of shock. If you abstract out those patients, the mortality for the younger group was only 3%, and you can see there was no mortality for the octogenarians. We were able to get a RAND quality of life questionnaire on 75 of the survivors, and the significant difference was, perhaps might be expected, the perception of physical functioning was better in the younger group, but there was less perception of role limitation for emotional issues in the older group. And perhaps what's even more significant is what's not significant. That is, there's no difference between the groups in the perception of role limitation by physical issues, energy, emotional well-being, social functioning, pain score, or general health. So on the basis of our experience, we concluded that octogenarians can undergo emergency surgery for type A with a low hospital mortality. Survivors recover a good quality of life, and we recommend a biologically based, not an age-based treatment approach. So moving on to the second part of the talk, extending the classic repair. I think at the outset it's worthwhile considering what are the goals of surgery for acute type A. And for the Asimov fans in the audience, I think the primary goal, or the primary directive, as he would say, is to correct the immediate life-threatening pathology. That means resect the aorta most likely to rupture, restore or preserve aortic valve competence, restore vital perfusion, which includes, where possible, resecting the tear and directing flow into the true lumen. Secondarily, down the line, we would like to prevent root dilatation and promote healing and remodeling, and that includes, if possible, obliterating the false lumen. So it seems to me the logic for extending the classic repair rests on a sequence of premises. The first is that there's a patent false lumen in most patients following repair. That leads to an increased rate of expansion, which leads to a high rate of distal reoperation, attended by a high reoperative mortality, which ultimately results in decreased patient survival. And I'd like to look at the literature that supports each of these premises. Starting out with false lumen patency. This is a paper of Dr. Ergens and Dr. Greeps from the Sinai group from 1994, 58 acute type A's. It was at the beginning of the series. And indeed, it showed that there was a significant false lumen patency, 47.3% in this series. And I think it's generally true that the literature supports that there's a significant false lumen patency after the classic repair, sometimes ranging as high as 50 to 75%. What about the patent false lumen increases the rate of expansion? This is a paper by Fattori from 2000, and as opposed to an occluded false lumen, there was, in fact, a higher rate of expansion with a patent false lumen. Here's another paper by Kimura. I'll refer to this a few more times in the talk. It's a good talk, a follow-up, meticulous follow-up study in 139 type A's with serial CT scans. And as opposed to the thrombosed group, where there was actually remodeling of the aorta, there was an increased rate of expansion if the false lumen was patent, particularly in the proximal descending aorta. What about the high rate of distal reoperation? This is a paper by Fatouche from 2009 with 189 acute type A's, and visibly there was less intervention if the false lumen was occluded. In fact, at 10 years, the difference was 94 versus 64%, which was significant. But there are a number of papers to the contrary in the literature. This is a paper by Kimura from 2008. It was actually a larger series conducted really over the same time frame. And in that series, there were only 8 late re-ops in 8 patients. 7 of those were elective, and the re-op mortality was 0. This is a paper of Dr. Halstead's from the Sinai group, 179 consecutive acute A's with more extensive follow-up, the follow-up extending to 18 years. And again, this was a detailed, meticulous study with digitized serial CT scans. And the cumulative probability of distal reoperation at 10 years was 16%. There were 25 late distal reoperations in only 16 patients out of the 179. Now, 31% of Marfan's patients did need a distal reoperation, but only 8% of the 142 non-Marfan's patients needed a distal reoperation, and there was only one mortality, or 4%, in those reoperations. This is our series at Westchester, 105 acute A's, and there were only 8 distal reops in our follow-up, and all of them were in the arch or proximal descending, and the reop mortality for all 8 of those was 0. Regarding patent false lumen and decreased survival, there is some indication of this from this 1982 DeBakey paper because the type 2s seem to fare better than 1 or 3, and there was, of course, no false lumen in the type 2 at all in the descending aorta. This is a paper of Fatouche's from 2009, the one we saw before, and in terms of 10-year survival, once again, it appeared to be better with an occluded false lumen, 90 versus 60%. But once again, there's literature to the contrary. This is Dr. Ergens' paper from the Sinai series with no difference in 5-year survival. This is the Kimura paper with no difference out at 10 years. And the 10-year survival was in the range of 80%. So going on with the logic, it goes that there's a false lumen which triggers a sequence, and ultimately that leads to decreased patient survival. and extending the classic repair will lead to better outcomes. Now, the extension that's being trialed at a number of centers is a modification of Dr. Boris' elephant trunk procedure, converting it to a one-stage procedure, the fixed elephant trunk, or perhaps more painful, at least for the elephant, the frozen elephant trunk. And going on with the reasoning, if you extend the classic repair with a stent graft, that will lead to thrombosis of the false lumen and remodeling of the aorta, which will lead to decreased late reoperations. It won't be confounded by increased important complications, and therefore patient survival will increase. And I'll briefly look at each of these steps. This is a paper that was presented here at the Aortic Symposium 2 years ago, the early experience from the Evita registry with 65 fixed elephant trunks. And in the false lumen at follow-up, they did achieve what they hoped. There's complete thrombosis in the overwhelming number of patients. But distal to the stent graft, and I think this is typical of a number of similar studies, most of the false lumens are patent, and in fact, in an equal number, there's partial thrombosis, and there's some evidence from IRAD and other studies that this may be even a worse scenario. In terms of decreasing late reoperations, this is that Evita paper, the distal reop rate at 4 years was 18%. Now, this is just their early data, but in comparison with larger studies extending out with more follow-up, you can see the re-op rate is only 4 to 8% in those studies, and the mortality for those reoperations ranged 0 to 4%. What about decreasing late reoperations? This is a paper by Uchida with 120 consecutive type A's, and it was a surgeon's choice as to whether the patients underwent a full arch with a fixed elephant trunk or had a more classic type A repair. And it did look like the the frozen elephant trunk patients had fewer late interventions, but this was not a randomized study. This was surgeon's choice, and perhaps patients who were frailer and higher risk weren't offered a more extensive procedure. I only have time to mention one complication. Dr. Zito had a really great paper on late possible complications, but I want to mention paraplegia because it's a very important one. The longer the elephant trunk, it's possible to increase the rate of paraplegia, and a number of centers are trying to limit it below T7 and T6 on that account. It's almost unheard of for a patient who does not have spinal injury to have a post-operative paraplegia after a classic type A repair. So I think this is a significant point to be watched. This is a collection from the literature from the Hanover group entitled The Elephant Trunk 27 Years After Borst. And in this table, they collected series of frozen elephant trunks. And with a sum of 700 patients, about 60% of which were dissections, you can see this is actually a 5.6% incidence of paraplegia. What about increasing survival? This is that paper of Uchida's that we just looked at. It does look like the frozen elephant trunk has better survival, but really out at 10 years, that survival is no different than the survival that we saw with the large classic studies so far. So summarizing the logic for extending the classic repair, the false lumen is patent in most patients following repair. I think that's true. It leads to an increased rate of expansion, primarily in the distal arch and proximal descending. I think that's true. Leads to a high rate of distal reoperation that's attended by a high reoperative mortality. I don't think that's true. And therefore, it decreases patient survival. I don't think that's true. Adding a stent graft will cause thrombosis of the false lumen and remodeling of the aorta. Well, that's true at the level of the stent graft. Remains to be seen what's going to happen distally. That leads to decreased late reoperations. That's not true. It's not attended by significant complications. That's not true. And will increase patient survival. Well, I think that remains to be seen. So in conclusion, the prime directive, it's been mentioned a few times during this symposium, is to have a living patient leave your OR that night. Now, some centers should be trialing extending the classic repair with the goal of decreasing late operations, but I think that's with the idea in mind that this is perhaps a more low-frequency, more moderate risk event than is often claimed, and I think they should be offering this extended operation if they can do it with no increase in mortality or morbidity, particularly paraplegia. So I think that for most centers, regarding the fixed elephant trunk, I think the classic advice is good advice. Thank you.